you know that there are the different troponins, and according to the IFCC criteria, the troponin should be high sensitive, considered if they have a total imprecision at the 99 percentile value and less than 10% CV. So the measurable concentration between the 99 percentile should be attainable within an assay at concentration value above the assay limit of the detection for at least 50% of the population. So this is the criteria according to the IFCC, if we are claiming for the high sensitive troponin I. So this is the troponin I assay to be considered. There are some cases in which the Roche generation 5 is not meeting the criteria for the next generation. And if we talk about the troponin T versus I, the hemolysis up to the 0.1 grams of per deciliters may have an impact on the troponin T, which falsely depress results, while the troponin T of the Roche hemolysis diagnosis interferes occurs at low level as compared to the other assays. And also the biotin interference safety communication has been given by the FDA, which shows that the high sensitive troponin T not be taken from the patient who has taken a therapy with the high biotin dose greater than 5 milligram per day until at least 8 hours following the last biotin administration. So these are the few cases in which the biotin has an interference. And this is the troponin T drawback about the rhythmic variation and the diurnal variation in general population that is not seen with the high sensitive troponin I. And you can see at a different time, like 8 a.m. in the morning, 2 p.m. and at 8 p.m. it's a troponin I value this decreases, and it comes on variation by the gradually decreasing concentration during the daytime and the rising concentration during the night time to peak concentration in the morning. So this rhythmic variation is irrespective of the sex and the glucose metabolic status, and it may lead to the differential event. And also in the POMI disease is associated with the skeletal muscles. The possibility of troponin T raise is 82% as compared to the conventional and the high sensitive troponin I. And then also the CKMB has a probability of 59% elevated in the Pompe disease, which shows you that the false positive diagnosis of cardiac injury when the skeletal muscles pathology is present. So if we talk about the high sensitive troponin I specificity as 2 hours compared to the troponin T, having a higher sensitivity and specificity at these hours. And this is the algorithm for the troponin T and troponin I assay. If we talk about the current challenges, around 17.3 million people in the world are caused death for the globally due to this cardiovascular diseases, and it's an estimated about 23.3 million people by 2030 maybe died from the cardiovascular disease. So the emergency disease need to improve the patient outcome, the overcome condition. So with the contemporary or a conventional troponin assay, the analytical challenges are the lack of precision, the sensitivity, the robustness, and the gender-specific cutoff. While the clinically they have analytical variability, the cutoff and the length of the time, and the negative predictive value and the positive predictive value. Along with that, this contemporary troponin I limit of detection 99 percentile, and defining the high sensitive troponin I according to the International Federation. The total imprecision at the 99 percentile value, which is less than 10% coefficient of variation, and the 50% of healthy individual. So according to the European Society of Cardiology, it is a recommended interval to repeat the test after initial assessment with the high sensitive is the 3 hours. So within 3 hours, the patient can be rule in, rule out about the myocardial infarction on the basis of high sensitive troponin. So the conventional troponin I takes 6 to 8 hours to rule out that. So with the high sensitive troponin I, this is the analytical characteristics of commercially available high sensitive troponin I. If we go for some more analytical sensitivity versus the other competitors, and then the limit of detection on admission at 30 hours, the negative predictive value on high sensitive is more as compared to the conventional. So the rule in improvement identification with admission samples of less than 99 percentile, the 3 hours has the rule out in high sensitive is 83.0% positive predictive value as compared to the conventional troponin I is the 57.4%. So if we talk about intended use and then the improvement assay, this is then a briefing analytical and clinical value. So the improvement in the assay precision is less than 6% and 99 percentile. And for the chimeric antibodies, for the heterophilic robustness and the gender specific 99 percentile diagnosis cutoff, and for the healthy subject as well for this. So if we talk about some cases, the calibrators and the manufacturers, and then the top values for different. This is are the NACB recommendation for the analytical guideline, acute chest pain, and the rule out of high sensitive, early rule in and rule out of algorithm for the myocardial infarction. And if we go further for the risk stratification, so the high sensitive troponin I is also can be used for the risk stratification. If we talk about what is a risk stratification, is basically an apparently healthy population for the future cardiac event with the high sensitive troponin I. Using this high sensitive troponin I risk stratification is an act of identifying, predicting with that low, moderate, and elevated risk. So if we go further for this high BMI global value, so this is and what do we do today for the risk stratification tool? According to the Framingham 2008 guidelines, the age, sex, smoking history, and total cholesterol, HDL, and systolic blood pressure. These are the risk stratification tool, along with the systolic blood pressure, diabetes mellitus, and the blood pressure treatment. And then a score of ACCA is a similar multivariable assessment is also required. The lipid profile values monitoring is also significant for the risk stratification, along with the high sensitive CRP and biomarker for the chronic inflammation. So for the determination level of the risk as a risk stratification, at a low risk, the lifestyle advice is recommended. If in case of the moderate risk, lifestyle and consider the drug if it's uncontrolled. For the high elevated risk, the lifestyle advice and with the drug treatment is also recommended according to these guidelines. And these guidelines are being taken from different practical European guidelines. And according to that, these are very much important for that case. If we go further for some values, then there is a limitation of this current tools. According to the scores of Framingham 2008, there are some current tools to focus on the lipid blood pressure assessment, which also have some journal body risk and also the necessary risk specific to the heart, and also the risk inaccurate risk predictions also with the some tools which overestimate and underestimate the cardiac risk and do not take into account ethnic variability as well. So if we talk about the values which are correlated with the troponin levels with the sex specific current based upon the risk level, these are available from the other platform. These are the low, moderate, and high risk. If the troponin value in terms of picogram per ml in the male is less than 6 and in the female is less than 4, it's considered as a low risk. If it's between 6 to 12 in the male and between 4 to 10 in the female, it considered as a moderate risk. And if it's elevated above 12 and greater than 10, these are considered as an elevated or a higher risk troponin value for that patient risk in stratification. So these are a few evidence which supporting the risk stratification using that troponin, and there are few publications which are related to the impact of sex on the prognosis value of high sensitive troponin in the general population, and what is the value of risk stratification with high sensitive troponin I to the patient. So there are few key points. Number one, it's the aid in the predictive future cardiac event, even when the no symptoms or the sign of cardiac disease are present. And the second is the simple blood test compared to the multivariable assessment of existing risk stratification tool. It can also be added to the existing wellness check offering for the risk stratification of the myocardial infarction. And also it gives the patient with the more information to work with their physician to reduce their risk of future cardiac event. And it's also provided additional knowledge to make the lifestyle change to improve their overall health. So these are the factors which we can use this risk stratification about that, and then the early rules in the rule and out of the acute myocardial infarction, and this is about the high sensitive troponin ISS. So this is few information about, if we go to the back, here is the conclusion. The troponin I, which meet the IFCC criteria to be considered a high sensitive, and they have a robustness. There is no hemolysis impact, no biotin acetylation effect, and then about that. So this test can also be used for the risk stratification, but in the SNI package insert, this is all just used for to early rule out of myocardial infarction. And still there's some epidemiological distribution based population risk stratification values are also needed for that. So this is an information that I have for you for this case. If you, I think your question related to for the risk stratification is respond in that. So any other question, if you have, we can see that. Okay, let me check with you can send this presentation. So Anton K, if you need any presentation, you can ask to your Chinese colleague, and then they can share with you because they will send you, right? So if you have any more question, you can ask. Otherwise, we have to move to the next presentation, and before that, we have to take a 15 minutes break. Is it okay? Thank you, Mike. Thanks. So let's have a 15 minutes break or a 10 minutes break. What you want? Okay. Okay, let's have a break. Thank you. Hello, good afternoon. So let's start with the NT-proBNP and the BNP. These are the novel diagnostic screening tool for the heart failure. So let's start with the NT-proBNP and BNP. So in this presentation, we have four parts. The first part about the heart failures, and in which discuss about the BNP and proBNP introduction as well. In this presentation, we will also use about the clinical utilization of these two assays for also for the prognosis markers of NT-proBNP, and also the key benefit of SNIPE, NT-proBNP, and BNP assay. So let's start with this heart failure introduction. So if we talk about the heart failures, as you know, that according to the American Heart Association and American College of Cardiology, you can see here, according to this management of heart failure, the heart failure is a complex clinical syndrome that results from a structural and the functional impairment of the ventricular filling or the ejections of the blood. So according to that, this comes in the overview of the heart failure criteria. And if we talk about the epidemiological distribution of coronary heart diseases or the heart failure, it is the world most common cause of death. If we have a major public health problem, and its prevalence is around 508 million, that's in USA, and over 23 million people worldwide are impacted with the cardiac heart failures, and that's the mortality is high. So if we compare this heart disease If we compare the heart disease global epidemiological distribution, you can see here that's in heart diseases are more common in Russian countries, and especially in the India, and then the Australian region, and it has more high risk factors of heart disease in the North America and the South America region, especially if we talk about the countries like Brazil, Argentina, Paraguay, the Peru, and then Ecuador and other countries are at a high risk of that. So if we talk about the other countries like United States and Canada, are also have a major public health problem in these countries, which also include some other countries like European countries of uh, France, Germany, Poland, Rome, and Ukraine as well as also. In other cases, like other diseases, are the liver cancers and are the second largest diseases. And then according to that, they have some prevalence of HIV/AIDS in more in the African countries, and especially with the countries like here you can see between the Algeria, Mali, Libya, the African countries of South Africa, including these countries. So overall, the global epidemiological distribution of the most prevalence of that disease is in cardiac diseases. So, if we go for epidemiology of the heart failures on the basis of the prevalence of the congenital heart failures by the genders and the age factors, you can see here that among the men and the women, you can see between age to 20 to 34, the percentage of population is 0.3%. But after the age of 35 to 44, the percentage of the population is impacted with the heart failures in terms of the men's are 1.8% as compared to the women is 1.5%. But at the age of between 55 to 64, it's a more congestive heart failure prevalence is more in the men, and in the later stage it increases in more in the men. But after the 75 years, the prevalence of congestive heart failure in the women is more as compared to the men. So this congestive prevalence of the congestive heart failure, according to the National Health and Nutritional Examination Survey, this Center for Disease Control and Prevention shows that data, the prevalence is more in the men in general as compared to the women. So if it goes further about the risk stratification of the heart failures, you can see here, according to the New York Heart Association, heart failure classification can be classified into class 1, class 2, class 3, and class 4. So in the class 1, there is no limitation of physical activities, and ordinary physical activities do not cause that symptoms. But the slightly limitation of the physical activities, they're comfortable at the rest, and ordinary physical activities cause the symptoms, is called in class 2 heart failure classification. If has a marked limitation of the physical activities, comfortable at rest, but less than the ordinary activities caused by the symptoms. So if we talk about the class 4, that's a severe limitation and discomfort with the physical activities, and this is system present even at the rest. This is called as class 4, the heart failure classification. So according to this classification, if we go further for the challenges of the diagnosis of heart failures, there are a few symptoms and the boundedness about that. If you talk about the breathlessness symptoms, the fatigue and the water sodium retention symptoms, that there and then auxiliary examination about the ECG, chest X-ray, and the walking test, also with the laboratory testing of the lipid profile, along with the CBC and the TSH values, also gives them a supportive diagnosis tool for the heart failures with the imagological examination of echocardiography, which have a no specific lack of standardization in these cases, and then a subjective or then a correlation of the symptoms for the prognosis were not statistically significant. So if we talk about the gold standard for the heart failures is still echocardiography, which as a results from the different centers are not comparable, but it's still this is in gold standards. While the blood testing is also for the monitoring and the diagnosis tool is an objective for that. These are the challenges of the diagnosis of heart failures. And then if we talk about the biomarker indication for the use, excuse me. So you can see that at the stage at risk for the heart failures, the markers are the BNP and the anti-proBNP. These are the preventive, and then for the also for the diagnostic tools, you can see that the BNP and proBNP are the levels that can help you for the diagnosis of coronary heart failure cases. And for the prognosis on adding risk stratification, pre-discharge BNP and NT-proBNP also helps to have biomarkers for the myocardial injury or the fibrosis or in other cases according to the guideline for the management of the heart failures as well. So if we go further about the introduction of the anti-proBNP and BNP cases, the physiological characteristics that how anti-proBNP release from the heart. This is the wall stress due to that which the heart releases this proBNP 1-108. And then this heart as in bloodstream contains the anti-proBNP and the BNP, which is an active protein, which is in a shortened half-life of just 20 minutes, while the anti-proBNP is an inactive protein which remains about 60 to 120 minutes. Half-life is longer than the BNP, and there is a higher sensitivity which directly correlate with the levels and overstretching of the heart muscles. So the BNP has more significant in the heart failure cases. And if we compare these both assays like BNP and the proBNP, you can see here that the assay time, the prevalence of that protein is in just in 20 minutes, and anti-proBNP remains in the bloodstream up to 60 to 120 minutes. The responding to the change in the blood is 2 hours as compared to anti-proBNP is just 12 hours. The monitoring value is also based on the response to the patient and condition in the real time, while the anti-proBNP is more favorable for the prognosis assessment as well. The cleaning and biological activities, the endonucleus clearance is biologically active, while the kidney clearance and the no biological activities for the anti-proBNP in this case. If the renal function has robust, that's no, and then its age influence has no on the BNP, while the anti-proBNP is also has a renal function and age influence is also existing there. If you talk about the clinical trial cutoff for heart failure excluding is 100 picogram per ml for the diagnosis, the 500 picogram per ml for the BNP cases, while for the age factors like less than 45 years of age between the 450 picogram per ml. And if we talk about for the diagnosis, they have a 900 picogram per ml between the 50 to 70 age and 1800 picogram for the above 75 years of age. For the drug influence, that the BNP is an RHBNP and ACI, and the anti-proBNP is also influenced by the diuretics and the beta blockers values as well. In vitro stability, they are unstable, but by anti-proBNP, there is the stable, so that's a highly specific marker for the coronary heart failures. If the concentration is lower in the blood of the BNP, while the NTP or BNP values is higher in comparison with the BNP as well. So if we talk about the clinical utilization of anti-proBNP overall for the diagnosis in the patient with the heart failure, and also proBNP is a risk stratification with the acute heart failure, and also for the differential diagnostic for the between the cardiac and the pulmonary disease, with the patient having its acute dyspnea, and the preoperative and intraoperative and postoperative monitoring of the cardiac surgery. This proBNP has a clinical utilization more as compared to the BNP. If we talk about the diagnosis of the heart failure, there is some suggested cutoff for the BNP and proBNP in several situations. You can see that to exclude the ADHF, the BNP value, cutoff value is less than 30 to 50, while the anti-proBNP value is less than 300. So the sensitivity is 99% versus the BNP of 97%, and the specificity is 68% versus 62 of BNP, and the productive predicted positive value, and the negative predictive value is more in anti-pro-BNP as compared to the BNP, which is 96% negative predictive value, and as compared to the 99%. So there are some different positive predictive value, which shows the indication predictive value, and the negative predictive value is also acutely decomposition heart failures, and the brain neutropenic peptide, and the N-terminals pro-BNP diuretics also with test with the glomerular filtration rate and the body mass index. It also has a clinical signification. For the anti-pro-BNP, the age stratified approach, if it should be a cutoff value is less than 450, if the age is less than 50 years, above 50 to 75 years of age is less than, should be a 900, and above age of 75, it should be considered as less than 1800 for that patient. And then the sensitivity and specificity for the anti-pro-BNP is significantly better than as compared to the BNP. So if we go for a further diagnosis of the heart failure in some special situations, the clinical dysfunctions, like a GFR is less than 60, the BNP value cutoff is less than 200, while the anti-pro-BNP is less than 1200, and on the basis of the positive predictive value 74 and 94, which is much better than the BNP. In case of the obesities, as also they have 170 for BMI less than 25 kg, and the 110 for the BMI between 25 to 35 kg. And then on the basis of anti-pro-BNP, it says a no adjustment for the BMI, which it should be less than 900. So the risk stratification cutoff, no adjustment for the BMI, is more clinically significant in the anti-pro-BNP. So this diagnosis guidelines are according to the Journal of the American Heart Association and circulation from 2015 and 2019 journals. If we talk about the differential diagnosis for the pulmonary dyspnea and the acute heart failure, according to the European Society of Cardiology, they have an initial evaluation on the basis of diagnosis, whether the shortness of the breath or the dyspnea is of the pulmonary or a cardiac original, is often difficult because both frequent present as a complication and then sequelae of the others. So for the presence with the shortness of breath, there's a clinical finding. If the BNP and the pro-BNP testings are ordered, the low ranges BNP is less than 100 and the anti-pro-BNP value is less than 38. So heart failure is unlikely. But if it's a BNP value is greater than 100 but less than 400, and the anti-pro-BNP value is greater than 300 as less than 1000, it's suspected for the heart failure, and then it's go for the echocardiography. So if the higher risk, the BNP value is greater than 400 and anti-pro-BNP value is higher than 1000, so the heart failure is likely, then the initiation of the treatment or the transfer to be a tertiary centers for the CT for the enhancement and the PE definitive text for that. But if in case of suspected heart failures, echocardiography will help them to check the etiology of heart failures. If it's negative, then go for the D-dimers, and then D-dimer is positive, then the PE likely, or if it's negative, then the PE is unlikely. So the further diagnosis with CT with the enhancement is also help to rule out the ARDS. And then if the primary steps are rapid on side available to rule out the heart failures, then the initial decision making steps helps them to further differentiate about the heart failure, unlikely, suspected, and the likely, with the support of some other echocardiography and the other supplemental testing helps them to take a secondary steps and then to diagnose the patient presenting to the emergency room with the shortness of the breath. So the BNP levels for greater than 400 picograms are strongly suggestive for the acute cardiac decompensation, and then echocardiography is recommended for the patient with the suspected HF. which includes those individuals which serum BNP level is 100 picogram per ml. So these are the differential diagnosis between the pulmonary dyspnea and the acute heart failure. And if we talk about more the pulmonary dyspnea and the acute heart failure on the basis of NT-proBNP value for the non-acute coronary heart failures and the acute coronary heart failure, would be differentiated into the pulmonary and the cardiogenetic issues that amongst that patient, 131 have no clinically significant increased value of NT-proBNP, while with the cardiogenic issues with the acute coronary heart failures, number of 209 samples has been tested. Around that, this shows that the value of 4054 in terms of the NT-proBNP value in the picogram per ml. So in patient with dyspnea and the NT-proBNP increased significantly in the group of patient with the cardiogenic dyspnea, but not only significantly in the patient with the pulmonary dyspnea. So the median NT-proBNP level among the patient who has an acute CHF, coronary heart failure, and those who don't have acute CHF boxes in irregular ranges, whiskers 5 to 95 percentile value is that. So this is about the differential diagnosis between the pulmonary dyspnea and the acute coronary failures. So if we go further for the pulmonary dyspnea and acute, there's some more some studies which show the median value of B-type natriuretic peptide measured in the emergency department with 3 different groups. So what were the 3 different groups? One group is the no congestive heart failure. Number of sample was 770 patients were ruled out, and then the dyspnea due to the non-cardiac cause by the patient with the history of left ventricular dyspnea. 72 patients were tested for the brain natriuretic NT-proBNP, and also with the 744 patient having a dyspnea due to the congestive heart failure. So that's been observed that there's a very elevated value with special marker for the beta type natriuretic peptides having clinical utilization more. So if we go further for some other risk stratification for acute coronary heart failures, if we compare in a symptoms classification on the basis of type 2, 3, and 4, the NT-proBNP values, predicted value is 0.001. And then in type 1, the value, and then type 2 correlation between the median NT-proBNP levels and the symptoms severity on the New York Heart Association classification, and that shows that the NT-proBNP has an important clinical significance for the assessment of the grading of the acute coronary heart failures. So this is the risk stratification for the acute coronary heart failures, and according to that, the BNP is also has a risk stratification on the basis of plasma BNP level in the patient having the severity of their exercise limitation based on NYHA classification. So if you further go for the severe COVID-19 situations, these BNP levels were increased up to greater than 100 picograms per ml, and the NT-proBNP levels between 450 to 900 and 1800 picograms for the age less than 50 and between the age of 50 and 75 and older than 75 age. So these are the algorithm for the severe COVID-19 cases management. You can see that all the patients should be in screen for the history of prior coronary artery disease, stroke, and structural heart disease, and then the chronic kidney disease as well. So the troponin estimation and the anti-peptide estimation of the BNP and NT-proBNP is also done for with the severe condition if the patient have the present with the new onset and resting anginal chest pain. That's the ECG is first, and the ECG is suggestive for the ACS. Then the cardiology consultation is required. If ECG is not suggestive for the acute coronary syndrome, then follow this algorithm. So the elevated troponin or anti-proBNP has an yes. If the yes markedly elevated, so go for ECG. And if they are at high risk for the CV event, then the urgent cardiology consultation and then urgent echocardiography with the ECG monitoring and with the D-dimer and serial troponin and anti-proBNP, and they decide treatment according to the likely cause. If the ECG is goes and there's a normal, then any one of both of the following two criteria, maybe the presence of less than 1% of these: coronary artery disease, structural heart disease, or stroke of the chronic kidney disease as well occurs. So only the 2% chance of the CV risk factors, including the DM and HTN, is occurs. So if the treatment of the comorbidities, the repeat troponin I and the nucleotic peptide after 3 to 5 days, and the early clinical deterioration is occurs. So, according to this severe COVID-19 diabetes and metabolic syndrome clinical research review publication from the Elsevier, that shows that they strongly advocate the role of estimated troponin and the nucleotic peptides, that's the BNP or anti-pro-BNP, N-terminal pro-hormone BNP, for the risk, for the cardiac risk stratification and prognostication of the patient with the severe COVID-19 pandemic. So that's a situation in which there is a joint detection, need more stringent monitoring for that, and then this joint detection of the different parameters will increase the diagnosis accuracy significantly. So if we talk about the anti-proBNP with the cardiac troponin I and HSCRP, there is a ROC curve which shows that increase. That's AUC when the cardiac troponin T, troponin I, anti-proBNP, and CRP words added to establish a cardiovascular risk in that patient for the prediction of incidence measured for the cardiovascular event within the steady correlate, and that's established a cardiovascular risk factor. So on the basis of this established risk factors, and then with the complement of troponin I, anti-proBNP, and HCCRP is shown. So if you go for a further about conclusion, these are the useful marker for the diagnosis of heart failure, and it is recommended at all stage of the heart failure. The continuous anti-proBNP and BNP measurement, including the baseline and post-treatment evaluation, is very helpful for the risk stratification and the monitoring. And the joint detection with the multiple parameters will also increase the reliability and the accuracy, sensitivity, and specificity of the heart failure. So this is about the conclusion for that. And if you go further for the recommendation application, there's some emergency physician clinician recommendation for the patient with the dyspnea. That's a recommendation for the clinical use in the early diagnosis and rule out of the heart failure, and for the prognosis and the risk stratification, and for the drug monitoring if the patient has a rule out for the CHF. For the surgeon, from the clinician point of view, this is utilization of these assays that the patient whoever proceed on a non-cardiac surgery, the risk stratification for the cardiovascular disease during the perioperative period and the post-surgery as well. About the cardiologist with the patient with the dyspnea and the heart failure, this can be differentiate on the diagnosis with the ambiguous symptoms and the prognosis and risk stratification. With the patient having heart failure, this is the guided treatment and long-term monitoring for the heart failures. If we talk about the oncologist, patient with on a chemotherapy, this assay having a risk stratification for any complication which is related to the cardiovascular disease, and also help them to monitor the cardiotoxicity of the chemotherapies as well, because some chemotherapeutic reagent has an impact on the cardiac muscles and may damage that. So if we talk about some more pediatrician, in terms of pediatrician, They have a patient with congenital heart disease. They help to diagnose the CHD in the children and prognosis of the CHD as well, also helpful for the pediatric patient by the clinician inducement. For the endocrinologist, this also helpful for the management of chronic diabetes and obesity. And if they have a both in combination with the hypertension, it helps to detect for the heart failure in the patient with the obesity and the diabetes along with the hypertension. For the nephrologs, people with the kidney damage, they have a problem with the chronic kidney disease, CKD. It's also help for the early detection of cardiovascular disease. If we talk about the physician, they have a high risk population: diabetes, hypertension, coronary heart disease, patient with the dyspnea and heart failure. It also helps to rule out and confirm the diagnosis of heart failure. It's also differentiate with other disease and evaluation for the heart dysfunction. It's also terms for the management for the monitoring of the heart failure as well. So, what the SNIPE has a solution for these risk stratification and cardiac marker specialized for the coronary heart failures. We have anti-proBNP and BNP assays. If we compare our BNP assays with the Simmons and Abbott, our assay has an utilization of principle based on sandwich principle. Excuse me. The sandwich principles. Along with that, the Siemens have also a sandwich principle. We have a sample type is plasma is recommended for the BNP in both generation, the first generation and second generation. We have a calibration interval for the 7 days, and they have a 42 days for the pack size and the 61 days for the lot calibration, and the reagent kit with the new lot numbers required by the Abbott. So, but according to my information, if they are using the same reagent pack or a reagent kit more than 28 days, their onboard calibration interval is 28 days, right? So the calibration interval in our case is just 7 days. If we talk about the onboard stability, we have a 4 days onboard stability, and the calibration on the onboard stability of Abbott product is 30 days, and the Siemens has 42 days. In terms of linearity, we are equally good in the second generation and the first generation. And if we compare with the other competitors, we have equally good. If we talk about the limit of quantitation and analytical sensitivity of less than 10 picogram per ml, and the package we are offering, we have a 50 test pack size and 100 test pack size, while the other competitors like Siemens and the Abbott, they have only 100 test and the 500 test pack size available for different platforms. But there's one more key about the competitors Abbott. The 500 pack size is only for Architect i2000 in the older version of their instrument, while in the LNT version, they have a capacity to load both 100 test and 500 test pack size. So if we talk about the product specification about the BNP, so you can see here the sample type. So the patient should be rest for 10 to 15 minutes before sample collection. These are the guidelines for the sample collection. Shorten tourniquet's time length, and then the avoid strenuous exercise before the sampling. So we have to take a feedback from the history from the customer or the patient that they are having any strenuous exercise before the sampling is not recommended. And the sample type should be collected in the plastic collection tube, because the BNP molecule is unstable in the glass container. So that's why it's recommended to collect in the plastic collection tube. Sample types: dipotassium EDTA or tripotassium EDTA, that's in a purple top tubes, are recommended, and the other sample types, including the serum, heparinized plasma, citrate plasma, samples provided a lower BNP value and are therefore not recommended. So this is very much important. The recommended sample tube is required for the to avoid any pre-analytical error for the detection of BNP assay. So the sample storage, if the sample is removed from the separator, red blood cells or clot, maybe takes up to the 4 hours, at 18 to 25 degrees centigrade and 2 to 8 degrees centigrade, the stability of the BNP analyte is 24 hours. So minus 20 degrees centigrade, this stability is 6 months, and the frozen specimen subjected up to the 3 freeze and thaw has been evaluated. So the limitation is about the 2 hour before and after the treatment with the recombinant BNP and the neural endopeptide inhibitors such as LCZ696, which is cause an increase in the BNP level for the treatment of the heart failure is recommended. So this is there's an instruction for the collection of BNP. If we talk about the NT-proBNP, we have also a competitor in the market, which are Roche and Siemens. They are using the same technique of principle, that's a sandwich technique. Both sample and serum and plasma types are recommended. Our sample volume is equally good, just 20 microliter as compared to the first generation and the Siemens, and also we have a calibration interval of 28 days, which is equally good to SNIPE, while the Roche has a 7 days onboard calibration interval stability for ProBNP, NT-proBNP. So on board stability, we have a 1 month. The other competitors have 8 weeks and the 4 weeks on board stability. So if we talk about the linearity, we have equally good linearity up to 35,000 picogram per ml in the case of NT-proBNP. We have a limit of blank detection and quantitation concept, and we are offering a smaller pack size of 50 tests with the conventional 100 test pack size, while the other competitors like Roche and the Siemens, they have a bigger pack size, minimum 100 test pack size or a 500 test pack size. So this is the all comparison about the NT-proBNP and the other competitors available in the market. So if we compare the SNIPE Meglumi menu, so you can see here for the specific cardiac markers, we have both like NT-proBNP and the BNP-S analyte. While the Roche has missing the BNP analyte, they have only NT-proBNP, while the Abbott has launched the NT-proBNP here, and while the Siemens has these both analytes. But the challenge from the Siemens platform, they do not have these two analytes from the same instrument platform, so they need to be place another instrument only for the just one parameter, because these are not available from the same platform. If you talk about the Bachmann Coulter, they have not available along with the Biomunics. They do not have the NT and ProBNP and ProBNP markers in their assay menu. So we, as of today, we have a very comprehensive menu for the coronary heart failures in terms of BNP and NT-proBNP assay. If we compare the method comparison of the BNP on the basis of 117 samples tested with the chemiluminescence immunoassay test kit with the BNP respectively, and on the basis of this analysis, you can see that the results between 0 to 6,000 BNP assay, the value is correlation is excellent. The regression value is 0.95, which is higher as compared to the other competitors, which is good. So if we compare with the comparison of NT-proBNP, we have a comparison with the commercially available other NT-proBNP assays. The regression value is 0.98 with the patient value of 0.0 less than 0.001, which shows an excellent correlation with the other competitors available in the market. So if we talk about any question about NT-proBNP and ProBNP, so there is a one generalized question about that: which one is better to be the marker of heart failures? So although these both levels are correlated with each other, but the individual value of those nucleotic proteins are not interchangeable. They have a different half-lives, a different mode of degradation, and most important, different ranges and cutoff. So the similarities for outward their differences and the purpose of the reading there should be considered basically equal. So both important principles should be underlined that clinical utilization. So if to rule out for the emergency patient, these both anti-pro-BNP and the BNP markers helps a lot. The second question is about how to diagnose when the results fall in the gray zone. So, as you know, that this clinical suspicions of the heart failures or the past history of heart failure probability is 75%, with this gray zone is defined as here. So, if BNP value is between 100 to 400 picogram per ml, while the anti-pro-BNP on the basis of different age, if considered as less than 50, that's the 300 and 450, and between 50 to 75, the value between 300 and 900. And if we talk about the 75 years above, that's between 300 to 1800 picogram per ml. So this gray zone needs an extra physician attention and ancillary testing when the final diagnosis is based on the mild to the moderate heart failures and other also causes for the rise in the NP level should be considered, which does include this non-cardial pathology that's also may cause a myocardial stress and also maybe a pulmonary hypertension and the RV dysfunction secondary to the pulmonary embolism. So overall, patient with the pneumonia can also have clinical suspicious of the heart failure or past history of heart failure. Probability is 75%. So according to this European Journal of Heart Failure, and how you can diagnose when the results fall in gray zone. So that's an all about BNP and pro-BNP. And let me share with you one more thing. That was a question which was related to the dilution and the reference range. Okay, let me check where is the document. Okay. Okay, I have few. So can you see my screen? So you can see my screen right now? Okay, Artem, you didn't. So this is the dilution suggestion protocol. The version is 1.3. Maybe if the latest version they have, the Chinese colleague, they will can ask you. Okay. So if we talk about all essays which are related to the thyroid, this is the measuring range document. And about if we talk about the cardiac marker, let's go to the cardiac markers. So if we make this little bit big, okay, no, it's too much. No. Okay, sorry. Let me check again. Mhm. So you can see here the cardiac markers. So on the right side of your screen, uh, you can see these are the cardiac markers. Okay. Excuse me. So for the assays like NT-proBNP, the linearity is between 10 to 30,000 picogram per ml. If the customers or the patient or the physician need exact value, the recommended dilution is 1:5 and 1:50. For the troponin conventional, there is a value is 0.01 to 50 nanogram per ml, and the value is 1. The dilution recommended dilution is 1:5 or 1:20. So this is all about the different dilution, the measuring range. If you want, this document also is available from the protocol. Like if you can want only for the cardiac, I can give you this. So I can share with you in the chat box. So now it's maybe helpful for you, right? So this is the measuring range, but you have to make sure the generation. Maybe the troponin I belongs to the second generation because the version is maybe some older version. Maybe I have. So you need to check whether this version is updated or not. You have to make sure compare with the package inserts linearity, right? So this is very comprehensive document for that purpose. So this is about that. And let me check your questions more if something is left so I can respond to your inquiries as well. So if you have any question, you can ask more. Let me share with you. Let me check if you have a time. We are 2 minutes higher than our time. Let me share with you one more thing. This is the essay summary. So maybe you have this. If you don't have, please contact to your Chinese colleague. Um, this is essay summary. So let me check where I have this in my box so I can share with you this important essay summary. Okay. So do you have this essay solutions, night protocol and the units? Urine? Do you have this? This is very informative protocol and the units, which shows you the more information about the essay. If we goes closer, this is the conversion factor for the Maglumi. We don't have. Okay, so Anton, it's my request. You can take a picture for this and ask to the Chinese colleague. They will provide you. So this is very informative conversion factor for the Maglumi parameters. Like if you are using the estradiol picogram per ml, and if the customer wants the results in picomoles per liter, so you can convert with 3.67 factors to picogram per ml result to picomoles per liter. So all these assay, their default units are these, and if your customers want the conversion of these unit from the conventional unit or the SI unit to the conventional unit, this is a good area of conversion factor. Otherwise, they can Google and then they can check from the internet that there's some conversion factor, they can use that. And these are the few more analytes which has some information about the sample types, like for HIV, procalcitonin, D-dimer, and albumin, what type of samples is required, and what are the sample type, and what are the sample type is used for the cyclosporin and tacrolimus. And if we talk about the renin, what plasma is required, EDTA plasma is required. For IgG, urine, ACTH, the plasma is recommended. So there's the one question why in some cases, in some hormones, the plasma is recommended rather than the serum. So the reason is in some analytes which are very sensitive, their half-life is more in plasma as compared to the serum. That's why for the optimum assay use and for the utilization, there is stability at a room temperature and stability at 2 to 8 at -20 is also provided by the customers, by the manufacturers to the customers, so that they can be helpful to check the stability of that analytes at different temperatures. So here is the sample type is also recommended. Along with that, the basic information about the analyte. So here you can see about the TSH. You can see this is the reference range for the TSH in different trimesters, along with the different age in the women and the men. And this is the measuring range of our assay TSH and the calibration frequency and how much sample volume is required. So for example, if you are going to start a TSH, T3 and the T4 analyte at the customer side, so the 100 microliter, 40 microliter and 40 microliter is altogether is 180 microliter. So the 280 microliter is enough volume for the thyroid profile testing if the customer is using T3, T4 as a TSH on meglumi as analytes. So it's a very informative document. I hope you will receive soon. If you have any problem to get this one, please drop me a message. I have also shared with you my WhatsApp number. So when you drop in a message, I can send you with the kind permission to my leaders in China, and then I will send you this reference rate, because this is for everyone, for the consultant, for the application specialist, for the marketing specialist, because even for the salesperson, if they are going to the customer side and they have been asked by the operators or end users or lab manager how much volume is required if you want to run TSH, T3, T4 for the pediatric samples. So altogether, it's 180 microliter is the aspirating volume. If we put the 100 microliter as the dead volume, it's altogether 280 microliter is enough, including the dead volume, to run the thyroid profile on meglumi M series and X series analyzers. So this is a very comprehensive information. Whenever you want, you can use this, and it's also available in that for the all parameters, like for the torch profile, like for the beta HCG, and their own calibration stability and other all markers. So along with that, there's in the end, there's also some more parameters which has like growth hormones and their linearity, the calibration stability, and aspirating volumes. So this is very good document. You can be used for the help at the customer side and for the technical information. Yes, you don't have, you can ask to your Chinese colleague. If you don't have get this information, you can drop me a message on my WhatsApp 92300-8373-970. So this is my number, right? So you can send me the message. I will send you the same file on your mobile number, right?